Well, good morning, everyone. Thanks so much for joining us on this Thursday morning for our PrEP Updates webinar. We're really excited to host this webinar that we initially had planned back in, I think, beginning of June, and we've had to postpone several different times just with some stuff going on around our country and around our community that we felt were more important than focusing on this right now. But we're excited to have this opportunity to have this presentation and actually get it moving. So thank you all for joining us. Wanted to make a couple of quick announcements before we got started. First and foremost, we, along with the PrEP discussion, our team at NC AIDS Action Network has recently created a statewide PrEP petition. We typically have petitions that we pass around the community at all of the Pride events that we go to across the state. But in the midst of COVID-19, we know that all of those in-person Pride events will not be happening. So in lieu of collecting petitions at Pride events, we will be doing an online petition gathering option. So I've just shared that in the chat. I'll also share this in the follow-up email that we send later today. But would really appreciate it if you looked over that. It's got a couple of steps for our state government as to how to expand access to PrEP and PEP here in North Carolina. So take over that, take a look at that. We would really appreciate you signing on to that if you are willing, in lieu of our annual Pride tradition of passing petition signatures around at all the various Pride events. A couple other announcements. We're excited to officially announce that on November 13th and 14th, we will be hosting our first virtual Building Power Across the Spectrum. So every year we host our annual HIV advocacy conference. It typically bounces around the state in different locations, but with COVID-19, we've decided to move to a virtual format. So the save the date will be going out soon and registration will be live shortly, but just wanted to go ahead and flag that for folks that on November 13th and 14th, we will be hosting Building Power Across the Spectrum virtually. It's going to be a lot of really great sessions with really great presenters. So make sure you flag your calendar for that, and hopefully you can join us on the 13th and 14th. And then finally, last night we kicked off our GOTV efforts that we typically do every year with our first virtual phone bank. It was a little bit different than other phone banks we've done in the past and other GOTV efforts, but we had a small little group that joined on Zoom. We did a little bit of a discussion about the importance of vote by mail and making sure that folks are aware of that. And we will continue to have those GOTV efforts throughout the next couple of months. So if you're interested in getting involved in that, please feel free to reach out to me. You will have my email in just a little bit whenever we send our follow-up email from today's presentation. But there's a lot of work that needs to be done to make sure that folks are able to get out and vote safely. So if you are interested in getting involved with that, reach out. There will be a bunch of different opportunities in the coming months as we lead up to election season. But other than that, I think that's it for announcements. And I think we are ready to go ahead and get started with the presentation. So we were joined by two of our colleagues today, Ariana Fisher, who is a master's student at the Sanford School of Public Policy at Duke University, has been helping us out with a lot of really great PrEP research, specifically around PrEP and PEP pharmacy distribution and some of the policy efforts that are going on across the country with that and possible steps that we can take here in North Carolina. And Case Van Dam, who is a doctor at RCID in Greensboro, and as a part of the HPTN 083 PrEP Injectables trial, who will talk a little bit about some of the results around that and really great findings that we're seeing with that study. So without further ado, Ariana, I will pass it over to you and the floor is yours.
Great, thank you. Let me go ahead and share my screen. Okay, can you all see that okay? Awesome. So as Matt said, I was asked to do some research on allowing pharmacists to distribute PrEP and PEP. And so that's what I'm going to be speaking about today. There's some really exciting policy updates around these efforts. I thought first I would just give a brief background of what PrEP and PEP are and how you can access these medications, just to make sure we're all on the same page, and then I'll move into the policy changes that we are seeing. So the two preventative medications I'll be talking about is pre-exposure prophylaxis and post-exposure prophylaxis. So pre-exposure prophylaxis, or PrEP for short, is a preventative medication that keeps individuals from contracting HIV. So it's a prescription that you can get through a doctor or nurse practitioner typically by going to your doctor's office or to a health clinic. And during that appointment, you'll get an HIV test done. You'll receive a consultation about ongoing care. And then if you are HIV negative, you can start taking the medication. This is an ongoing prescription, which, as I mentioned, does require ongoing care. So you would need to take an HIV test every 3 months. And then your doctor will monitor other functions as well, such as monitoring how your kidney is functioning. Post-exposure prophylaxis, or PEP for short, is a medication that's used in emergency situations. So if you think that you have been exposed to HIV, this is a medication that you can start taking within 72 hours after possible exposure. And that's according to the CDC guidelines. So again, you can go to your doctor's office and meet with your doctor or nurse practitioner if you're able to make an appointment within that 72 hours. But there have been a lot of reports about people going to an emergency room because that is such a short timeline, which of course is much more expensive than seeking a prescription through your doctor. An HIV test is recommended, but is not necessarily required. So that's the difference between PrEP and PEP. And then this is a one-time 28-day prescription. So that the difference between these two medications is that you can proactively take PrEP or retroactively take PEP. So there have been access issues that are important to think about when advocating for access to PrEP and PEP. The slide is not a comprehensive list of these access issues, but are 3 of the issues that I saw when I was doing this research. First is that many patients report facing stigma around meeting with the physician and talking about PrEP or PEP. So some of the issues have been that not all doctors are familiar with both of these medications. And then also some patients have reported misconceptions about their sexual activity that a doctor has projected onto them. So that has been a barrier for access as well. Second, access to PEP is limited at nights and on weekends. So, of course, it takes time to make a doctor's appointment, and so your time frame for 72 hours may run up to the weekend. Like I mentioned, your alternative is to go to an emergency room, but of course, that's much more expensive. And then third, there have been concerns over insurance pre-authorization requirements. So there were reports about authorizations taking 3 days in some cases for someone who was trying to get a prescription for PEP. Of course, if there is that much of a delay, then it's not effective for you to start taking PEP at that point. And so that has been a big issue as well. So those are some of the access issues that these new policy efforts have tried to address. And so states have increasingly started looking at allowing pharmacists to prescribe PrEP and PEP and aiming to address these issues. The first state to move forward with increasing access to specifically PEP outside of seeking a prescription from a physician was New York State. Initially, the New York City Department of Health and Mental Hygiene released a survey for pharmacists to assess their willingness to dispense PEP starter packs. So their proposal was to allow an individual to get an initial 7-day supply of PEP from a pharmacist, and then the pharmacist would link that individual to a physician for an HIV test and the remaining 21-day prescription. I posted a comparison here of the New York State clinical guidelines and the CDC guidelines for when someone should initiate PEP. So New York State says that the ideal time for initiation is within 0 to 2 hours after possible exposure. So that is very fast. And so they want someone to be able to just go into a pharmacy if needed, have access to this medication as soon as possible, and then they can get connected to a physician for the other requirements to start taking the medication. So after the survey was conducted, the health department addressed some of the concerns that pharmacists had around dispensing these PEP starter packs. And then the New York State Board of Regents issued a standing order to allow pharmacists to dispense these. That was effective as of March 2017. So since then, pharmacists in New York State are able to opt in to dispense these PEP starter packs. Inspired by this bill in New York State, the next state to make progress in this area and to take it a step further was California. So California wanted to push for a legislative change, which would allow pharmacists to prescribe both PrEP and PEP. And so the two groups that came together to push this forward were APLA Health and the California Pharmacist Association. So they drafted the initial legislation and pushed these efforts forward. Initially, the idea was to allow pharmacists to prescribe PEP as needed and then PrEP on an ongoing basis. But they faced a lot of pushback in pushing this effort forward because if you are on PrEP, then it does require continuous care. So the final legislation, which was passed in October 2019 and effective as of January 1st this year, specified the following. A pharmacist can administer and interpret an HIV test. They can prescribe PEP as needed, so that's the 28-day prescription, and then prescribe a 30 to 60-day supply of PrEP for a given individual within a 2-year time period. So after they prescribe that initial supply, they're linking patients to a primary care provider for the remaining ongoing prescription. And then also the bill removes insurance pre-authorization requirements for both PrEP and PEP. Now, on the pharmacist side, there are a few steps that need to be taken in order to be able to start prescribing these medications. So first, a pharmacist has to complete a board-certified training that covers information such as what PrEP and PEP are, interpreting an HIV test, logistics in terms of linking somebody to healthcare after their initial supply of PrEP, and other topics like that. And then after a pharmacist goes through that training, they are able to, again, opt in to be a prescriber for PrEP and PEP. In terms of next steps for California, the state's pharmacy board was given 6 months to develop a pharmacist training program. So the training was completed and rolled out as of July 1st, so last month. And so this is a very new policy. There aren't any impact numbers yet, but there were a few initial estimates that the California Health Benefits Review Program rolled out when this bill was being considered. So their estimates are they will see a reduction of 25 new HIV cases from using PrEP within the first year post-mandate, so after this July 1st date. They also project a 2% increase in utilization of PrEP by private insurance and Medi-Cal enrollees, and then a 2% increase in utilization of PEP by private insurance enrollees. So it'll be really interesting to see what the actual numbers look like about a year from now. Very recently, Colorado became the next state to pass policy changes in this area. So their bill was first introduced in January of this year, and then voting was paused due to COVID-19. However, this summer, the bill was picked back up because they linked the PrEP and PEP access bill to COVID-19, and then it quickly passed the state House and Senate and became law after the governor signed it last month. So there's a quote that was released from one of the primary sponsors of the bill, Senator Dominic Moreno, that I included on this slide, and he said, 14,000 Coloradans live with HIV today. That's 14,000 people with compromised immune systems who have increased vulnerability to viruses like COVID-19. Both HIV and COVID-19 disproportionately impact communities of color, which is why this bill is critical to expanding access to preventative medications for those who need it most. So I included this quote because Colorado did a really great job in how they framed the policy and also their timing. So they linked it to COVID-19, and then it quickly was picked back up and passed. And so that's something that Colorado was able to do really well. In terms of next steps, the state's pharmacy board is now working on developing a pharmacist training. So that should be available at the end of 2020, and then pharmacists can start taking the training and again opt in to being prescribers. In terms of what the bill itself included, Colorado is different because there's no quantity limit of PrEP that a pharmacist can prescribe. So the goal here is for pharmacists who become ongoing prescribers who will monitor patients who are on PrEP full-time. Otherwise, the bill includes similar aspects to California, such as ordering lab tests, consulting with patients, dispensing PEP, and then it also banned the prior authorization requirements for PrEP and PEP. And so any other details will be outlined at the end of the year once the Pharmacist Board releases their trainings and protocols. So those are the states so far that have passed standing orders and legislation around PrEP and PEP. There are 2 additional states that have proposed similar legislation this year, but that just haven't passed yet. The first is New Jersey. Their bill is very similar to California's, so I won't go into much detail. But the lead sponsor indicated that they're prioritizing COVID-19 related bills right now, and so there's no timeline for when this bill will be voted on. Oregon is the second state, and their bill has faced a lot of opposition, so I wanted to spend a little more time talking about that and some of the barriers that they faced. Oregon's bill was introduced in January of this year. Similar to other states, it proposed removing the insurance pre-authorization requirements. But a difference in Oregon was that they were not planning to allow pharmacists to conduct the HIV tests and interpret them themselves. So in order for an individual to be prescribed PrEP in Oregon, they would have to show proof of a negative HIV test first, and then the pharmacist would be able to issue the prescription. And then in terms of PEP, there would be no HIV test requirement. The bill was reviewed in a public hearing in February of this year, and like I mentioned, faced a lot of trouble there. There were representatives from Kaiser, America's Health Insurance Plans, and the pharmaceutical industry who spoke in opposition of the bill. And they had 3 primary concerns that they spoke about. I do want to call out that their concerns were specific to PrEP. So they noted multiple times throughout the hearing that they did not have any concerns about the PEP piece of the bill. And so their biggest concern was that the bill text was very vague. It didn't specify whether or not pharmacists would be ongoing providers of PrEP. It also didn't say anything about the HIV testing, so that's just something that I learned from reaching out to the primary bill sponsor. And so that was a big point of contention throughout the hearing. There were also a lot of concerns about how this would alter the scope of practice for a pharmacist. So thinking through whether or not pharmacists would have time to meet with patients and consult with them before prescribing PrEP. So that's typically like a 30-minute appointment. And so questions about what that process would look like that just weren't yet available at that time. And then the pharmaceutical industry representative spoke about concerns about removing the pre-authorization requirements. So the bill was not voted on in the legislative session, and so now the bill is considered dead. However, the primary sponsor of the bill, Representative Doherty, confirmed that she plans to have another representative reintroduce the bill in the state's 2021 legislative session. So hopefully we do see this bill come back. There will likely be tweaks to address some of the concerns that were discussed in the hearing. And then also Representative Doherty indicated that the state's pharmacy board has already started drafting these rules and protocols. So there should be a lot more clarity on what pharmacists would be allowed to do in the state once those protocols are ready. And so a critical piece that kept coming up when I was researching this is regarding HIV testing. So where the legislation has passed in California and Colorado, it's already in a pharmacist's scope of practice to order and interpret lab tests. However, that's something that varies by state. So South Carolina is an example of a state where pharmacists have a more limited scope of practice, yet they're still taking initial steps in the state to explore how pharmacists can prescribe PrEP and PEP. South Carolina was selected to be a part of the Ending the HIV Epidemic by 2030 plan, which is called Ending the HIV Epidemic, A Plan for America. In rolling out this plan, the USC School of Pharmacy and the Duke School of Medicine are working together to draft initial research efforts and carry those efforts out to allow pharmacists to prescribe PrEP. So these efforts are PrEP specific. What they'll be surveying pharmacists on is topics like their awareness of PrEP, their comfort in counseling patients, trying to see whether or not they would feel comfortable prescribing PrEP. After the survey is conducted, the researchers are going to conduct follow-up qualitative interviews to get additional information behind the survey results. So if there are pharmacists who are indicating that they may not be comfortable prescribing PrEP, hopefully these interviews would uncover some of the barriers that they anticipate facing, and then any legislation that's put forward eventually can help address some of those barriers. So ideally, at the end of this project, the researchers will be able to say how many pharmacists are in support of administering PrEP, what needs to be addressed in order for this to be rolled out in South Carolina, and then they can move forward with a policy change and convening stakeholders around this issue. So that's all that I wanted to talk about today. Those are all the state efforts to allow pharmacists to prescribe PrEP and PEP so far. I think looking at all of these states, it definitely makes sense to push forward PEP. I think it was really interesting in the Oregon hearing how they said specifically multiple times that the opposing side did not have any issues with the PEP piece of the legislation. So that was really important. And then, of course, if PrEP is pushed forward as well, that requires a lot more supporting evidence, such as what the pharmacist protocols and training will look like in advance. And I'm happy to take questions if there's time at the end, but I'll pass it back to Matt.
Awesome. Thank you so much for that, Ariana. I think that was really important information. And I know, Lee, you mentioned that you wanted to say a couple things. I'm going to pass it to you for a minute.
Yeah, hi everybody. Thank y'all for joining us. For folks who don't know me, I'm Lee Storo, Executive Director of North Carolina AIDS Action Network. Ariana, thank you again for all the research and work digging into this. Certainly this was a topic at the start of the year we were interested in taking a deeper dive into, and I think Ariana's done some really remarkable work to help give us the sort of global US context on this front. At the start of this year, we did, initiate some coalition conversations with some of our medical provider partners and pharmacists in the state around thinking about ways to advance this type of policy change in North Carolina. It's probably no surprise to anybody that when you look at the states Ariana mentioned, we are talking about states that are often perceived to be more progressive or more liberal than North Carolina, but we also don't want to not have those conversations here and, certainly feel an obligation to think through all our steps that we can use to break down barriers and access to pre-exposure prophylaxis and post-exposure prophylaxis. So for those of y'all who joined us on HIV Speaks on Jones Street, our virtual statewide advocacy day this year, we did start some of these conversations with legislators and certainly received some interest. I also have had some conversations with high-level staff at the Department of Health and Human Services about if there's any possibility of, particularly on the post-exposure prophylaxis side, moving forward with an administrative policy change that could allow that in North Carolina. I think Ariana's point about the impact of COVID is really astute. We at one point discussed maybe we need to pause these conversations because of COVID and because of so much energy going into that. But I think in some ways, thinking about in a COVID world of quarantining and restricted access to medical providers who are focused on COVID, if you were in a need of post-exposure prophylaxis in North Carolina right now and had, that limited time window of up to 72 hours, it could be really, really challenging to access that medication. We should treat post-exposure prophylaxis the way we treat Plan B for birth control. There's no reason that those shouldn't be treated the same and that access point really can't be a pharmacist. So that's a conversation we're going to continue to have. Are hopeful that either through an administrative policy change or through legislative action in 2021, we might see some progress on this. So I'll pass it back to Matt and to our next speaker, but certainly happy to have further conversations with folks, or if people want to reach offline with me to talk about this topic, certainly interested in that as well.
Awesome. And yeah, so we will try, if folks have any questions, just hold on to them for right now. We will try and have some time for Q&A at the end. I know we might be encroaching on the 11 a.m. time frame. So if we can't get to those questions, feel free to reach out to me afterward and we can get those answered for you. But for the sake of time, I will go ahead and pass it off to Dr. Kees van Dam with RCID.
Hey, thanks, Matt. Can you guys hear me okay? And Lee and Ariana, thanks for that really excellent presentation on PrEP. As an aside, I did want to let you know that now it's in the context of our clinic at the Regional Center for Infectious Disease in Greensboro. We actually do have a pharmacist who prescribes PrEP in our clinic. I mean, I sign off on her notes, but she sees the clients and prescribes PrEP, both for insured and uninsured patients. So we've been doing that here for a couple of years now. But again, it's the context of our clinic. So I'm really excited today to present to you guys some data about a new way of giving PrEP, which is through an injection instead of having to take a pill. And I'll pull up see if I can share my screen. So again, my name is Kees van Dam. I'm one of the infectious disease docs in Greensboro at the Regional Center for Infectious Disease at Cone Health. I oversee our HIV research as part of the AIDS clinical trial group. And also we have an HIV prevention trial that we participated in called 083. And I'm going to present the data from there and want to thank the principal investigator of the study, Rafi Landovitz from UCLA, for sharing his slides with me. So again, this data was presented at AIDS 2020, which was this year virtual. It was supposed to be in San Francisco live, but it was virtual. And this is going to be the final results of this study of HPTN 083, which is a study that looked at long-acting injectable cabotegravir, which is a different type of drug than you would see like in the conventional PrEP. And it shows that it's safe and highly effective for cisgender men and transgender women who have sex with men. And in fact, it was found to be superior to Truvada in this study. And these are the authors of the study. So my financial disclosures.
Really quick, Dr. Van Dam,
Yeah.
The screen share is not currently working, so try one more time.
Oh, let me go back. I thought I was sharing it. Share, oh, here.
There we go, that's it.
Can you see it now? Okay, okay, sorry. Let's see if it works now. Oops, go back. Okay, well, yeah, this is my first slide. You can see that, right? Is that working? Okay. Okay. So anyway, this is the 083 study, and those are my financial disclosures. So we're going to talk about a little bit of background of PrEP, talk about the 083 study design, and then I'm not going to dwell on all the statistical methods, but we're going to look at the results, which were really exciting, and look at the population and incident safety, and a little bit of details on some of the people who did contract HIV while in the study, and get to the conclusions of it. So this is just a broad overview of the PrEP as it was when this study began. We did not yet have the newer tenofovir, the TAF that's in Descovy. We had what we now, brand name Truvada. Tenofovir FTC was the one that was studied extensively. And you can see through these kind of color graphs, Truvada was found to be highly effective in certain studies, but largely depended on whether the people who were taking Truvada for PrEP were actually taking it. When they were not doing a good job taking it, of course, it didn't work. But that's just kind of the showing you that. And this is showing you some of the ones that had a high degree of effectiveness, such as the PROUD study, the Partners PrEP, and then the Ipirg, which is kind of a different way of doing PrEP, which is an on-demand PrEP where you take pills the day of sex and then in the days following that, versus taking it every day, which is the way it's approved in the United States. So these are some other newer drugs. On the left is a drug called dapivirine, which is being studied in Africa as a vaginal ring in women. And it's shown some varying degrees of efficacy of 27 to 31%. Again, seems to lot to do with how well these participants actually use the medication and actually use the ring. The Discover trial was one that showed, was sponsored by Gilead, that showed that tenofovir alafenamide FTC or Descovy was non-inferior to TDF, FTC, or Truvada. So this study 083 is the study we participated here in Greensboro, and this was a phase 2b/3 randomized double-blinded double dummy study throughout 43 countries in the world. It was more than about 4,000 patients globally. To get into the study, you had to be a man who has sex with men or a transgender woman, 18 or older. To get in, risk factors could be any non-condomless rectal anal intercourse, receptive anal intercourse, that is, had 5 or more sexual partners, used stimulant drug use, or had been found to have rectal or urethral sexually transmitted infection, or syphilis in the past 6 months. Or there's also a thing called a SexPro score, which is an online thing looking at various degrees, various factors, including ethnicity and age and things like that aren't captured by like looking at traditional risk factors for HIV in terms of like STIs and stuff. They had to be in good health, no active Hep B or Hep C, and no contraindication to having shots in the butt, which is where the injections were given. Couldn't have a history of seizures, and there you can see that. And the plan was to enroll 5,000 people, and the goal was to have at least half of them under the age of 30. As we know, certainly HIV has been disproportionately affecting younger people. 10% transgender women, again, very underrepresented population in most studies, and unfortunately a population that's disproportionately affected by HIV. And then in the United States, the criteria was that 50% of those enrolled will be Black or African American. And again, good reason to enroll them in a study such as this, because they're generally very, very underrepresented in studies of PrEP or HIV, and yet HIV is disproportionately affecting people of color in the United States, as an aside, as we were saying with COVID. So the primary endpoint was incident HIV infections during blinded comparison. I'm trying to get my slides so I can see a little better. Put this a little differently. Okay, and also the safety, which was any clinical adverse events. And this is the design of the study. So when participants were enrolled at screening and had informed consent, they were then randomized to one of 2 arms. One arm was the cabotegravir arm, in which they got cabotegravir. Now, the way this study is designed, what cabotegravir has been given in the United States in the studies, and it'll probably be approved with ripivirine, by the way, for treatment of HIV. But in any case, there's an oral lead-in where the person takes a pill every day before going to the injections. So on the top, you see the people who are randomized to get cabotegravir, and they were taking a cabotegravir pill every day for 5 weeks and a placebo pill of Truvada, and they didn't know which one they were taking, but on the top half, they were getting real cabotegravir and fake Truvada. When they got to week 5, they got an injection of intramuscular cabotegravir, 600 milligrams, and at week 9, and then that was continued for every 2 months for 3 years. And all along, they were also taking this fake Truvada, not knowing which one they were getting. If they failed to show up for study visits and were followed out of care and came back in, they were rolled over to step 3. If they completed the 3 years rather, then they went into the open label Truvada, where they got Truvada for a year. And that had to do with the fact that this long-acting drug, it takes a long time to get out of your system, and we wanted those participants to have protection while the cabotegravir kind of petered out of their system in the form of conventional PrEP or Truvada. The lower side is what the people got randomized who got Truvada. They took a fake cabotegravir pill with a real Truvada pill going into the lead-in. Then they got an injection at 5 and 9 every 2 months that looked, when you looked at the syringe, like it was cabotegravir. It was an intralipid solution, but it was just, it had no active drugs. So it was a fake cabotegravir injection. And then they were taking real Truvada. And that was continued on for 3 years. And then they were rolled over to continuing to take Truvada through step 3. And this is going to the statistical design, but this was, they're basically looking to see if injectable cabotegravir was non-inferior or just as good as Truvada. And this just gets into some of the statistics, and how much background HIV they thought there might be, and how much adherence to tenofovir, FTC, or Truvada there might be based on plasma levels of tenofovir. And then this endpoint of stopping analysis of when we start seeing that there might be non-inferiority or superiority. And so on May 14th, 25% of the endpoints were accrued, and it did cross this pre-specified stopping point, and the results were made public, and now the participants have been allowed to know what they're on, and the goal is now to offer everyone in the study cabotegravir as soon as it's available for everyone, because, as I'll show you, the cabotegravir was shown to be not just non-inferior to Truvada, but actually superior to Truvada in the study. And this is just showing the design of the study, how many people were randomized between the two arms of the study, between the Truvada and the cabotegravir arms. There were 4 people excluded from the intention to treat analysis, and then there were others who were excluded from the primary efficacy cohort. Some of that, there were 3 people in the Truvada arm and 2 in the cabotegravir arm who had HIV at enrollment, so they had to be excluded. And there's other individuals, 34 and 37, who were lost to follow-up. And this is looking at the study populations, and you can see that the types of patients, participants enrolled rather, were fairly evenly distributed. And we did, this just highlights that, we did get 12% transgender women, which was a goal. We did get well over 50% of people who were less than 30, almost 70% were less than 30, which is really, we know that's a higher risk population, a younger population. In the United States, we got essentially 50% Black African-American participants in the study as well, which was one of our key goals. So this is showing the HIV incidents that occurred in the study. So there were 52 HIV infections over 6,389 person years of follow-up. This gave a pooled incidence of 0.81 per 100 person years. If you look at between the cabotegravir and Truvada arm, you can see that there were 13 infections in the cabotegravir arm and 39 infections in the Truvada arm, for an incidence of 0.41 per 3,202 person years in the cabotegravir, or 1.22 in the Truvada arm per 3,187 person years. And then on the right hand of the screen, you can see the hazard ratio, and showing how that this shows that this data showed that cabotegravir met criteria for being not just non-inferior, but actually superior to Truvada, with a hazard ratio of getting HIV with Truvada versus cabotegravir of 0.34. And this is just another graph showing this HIV incidence as an intention to treat analysis. The blue dotted line showing the incidence of HIV in the Truvada arm, the orange one in the cabotegravir arm. And this is kind of getting into some of the details, but of the 13 people who got HIV who were randomized to cabotegravir, and it's kind of interesting to look at in detail. The little green viruses are when people actually were infected with HIV. Interestingly, in the study, the actual HIV infection were generally detected later at that time in terms of being detected at the site, but it was determined that when the actual infection occurred, though later. It was actually earlier than was picked up at sites. And a lot of that gets into the kind of complexity when you're giving an antiviral to prevent HIV. It can sometimes delay the diagnosis of HIV and can somewhat interfere with some of the tests. You have to be careful about that. But in any case, the first 2 individuals, A1 and A2, they were in the oral lead-in phase. Now, they supposedly were taking 93% of their pills, but this is based on them saying, sorry, I can't take this call right now, sorry. Anyway, those, that's based on them saying how many pills they were taking, not based on like blood levels. But in any case, oh, and sorry, those 2 people hey, it's Case, I'm on a conference call. Can you not call me back right now, please? All right, sorry. I'm sorry, I did not know how to mute that. Sorry, the first 2 participants actually did not get through their oral lead-in. They were started on oral lead-in, and 1 got to an injection, but they actually got an HIV. They actually had HIV infection at the time of enrollment. These next individuals if you look at B1, that person got through their oral lead-in of cabotegravir, then got injection, then had a gap in care, then got injection, then a gap in care, then was rolled into the Truvada arm, and then was not seen for some period of time, not on PrEP, and developed HIV. The next person, again, went an oral lead-in, then kind of lost a follow-up, later found to have HIV. B3 was a person who came in, was reliably getting injections for a while, then not reliably, and then got HIV. B4 was somebody who was switched over from cabotegravir to Truvada, and then got HIV. And then B5 is someone who started the oral lead-in and then was lost for many weeks, and then ultimately came back, found to have HIV. These other people, these are people who were, had the oral lead-in where they were supposedly taking 96 to 98% of their cabotegravir pills, but in any case, they did develop HIV infection while they were on the oral cabotegravir, which I would bet they were not taking as prescribed, but we're gonna need like blood levels and resistance assays and things to further tease that out. The ones that are kind of more interesting from, that would like to know more about are these 5 individuals here, because most of these people got through their oral lead-in, and again, that's based on self-reported pills, but then they made it to the injectable part, and most of these individuals were getting their injections on time. You can see the hatched area on D1 where someone was late to one of their injections. But if you look at these 4 individuals, they were for the most part, coming for their injections and getting them. But 5 of them did get HIV, and so it'd be very important to understand why these 5 people got HIV despite getting the cabotegravir injections at their sites. And this is just showing, again, briefly showing kind of like asterisks showing kind of when HIV was detected versus the green. Sometimes it was detected when it was detected at the site at the time that the actual event happened, but sometimes there was a delay. And again, this gets into some degree with the fact when you're on antivirals for PrEP, it can sometimes interfere with some of the tests. So you have to be very, very careful about that and talking to your patients. This is looking at the incident infections in the Truvada arm. And again, on the left-hand side, there were self-reported adherence to Truvada, and HIV infection occurred at various time points. These were people generally who were showing up and getting their bottles of Truvada. Again, they were getting injections and not knowing whether the injection was real or the pill was real, but they were, told, please take your pill every time and please show up for your injections. But in any case, these are the 39 individuals who got HIV in the Truvada arm. And I'm a bit confused about that. I'll have to ask Dr. Landowitz about those last 3 people, because it doesn't quite make sense in the graph to me. And this is again showing that there was some, like if you can see, some of these people, their HIV diagnosis was made later by the site than when they actually acquired HIV. And this is just kind of looking at the population in terms of tenofovir, how well our participants were doing at taking their pills. And you can see that, and this was basically people who were randomly selected in the study to get like dried blood spots, which help assess how much tenofovir the person was taking, or how much Truvada they were taking every week, or plasma for the past 2 weeks prior to them doing the dried blood spots, or plasma levels. And you can see that, the green is better. So like the intense green, it corresponds to taking it every day. The light green is 4 to 7 doses a week, which seems to be protective, sufficiently protective. Yellow, you're getting into more trouble. You can see across the study in general, almost 70% of those individuals were taking the Truvada at sufficient levels to get protection. There was some variation over time, as you can see in this graph. Now, I want to talk a little bit about injection site reactions, because that was one of the things that did happen in the study. Those who were getting cabotegravir did have some injection site reactions, more so than the ones who were getting the fake cabotegravir, where they were getting this lipid formulation injected into the butt muscle. And you can see that there was a fair amount of injection site reactions. But if you look at like how severe they were, most of these were mild or grade 1 to moderate. Very few were severe in those getting cabotegravir. And then you can see that on the right-hand side, the hatched thing shows the fake cabotegravir. And so that is one thing, is most folks did have some discomfort. They are getting a needle put into their butt muscle. And so some did have a little bit of reaction at the site. And there were 47 or 2.2% of the folks, 2,000 plus people, that were 2,500 plus people who were randomized who did stop their drug because of their injection site reaction. And those generally were people who were having severe injection site reactions. But as you can see, there's not a very large proportion of those who are getting the drug. In terms of injection site timing, most people will get an injection site reaction within the first 2 days of having the injection. And then it tends to last about 3 days or so afterwards. The types of reactions: pain, tenderness. Some people also would have a little bit of temperature elevation as well, as I'll show later slides. These are just looking at adverse events across comparing the Truvada to cabotegravir. We know that Truvada tenofovir can affect kidney function, and so there was a statistically significant difference where there were more individuals in the Truvada arm who had increased tenofovir, increased creatinine or reduced filtration rate in their kidneys as assayed by their creatinine clearance. For some reason, there was more runny noses in those taking cabotegravir versus Truvada, and then there was a little bit of elevation in blood sugars, more so in the cabotegravir versus Truvada, and there were a little bit more people who had fevers or elevated temperature. Typically, with the cabotegravir arm, that happened within 7 days of them getting the injection. And the people in the Truvada arm, remember, were getting an injection too. It just was fake cabotegravir, and some proportion of them were getting a little bit of a fever or temperature elevation within 7 days of the injection of fake cabotegravir. These are some other adverse events here, looking across both arms, but there was really not much statistical significance other than the creatinine clearance that I was showing before. And this is a graph showing that there was a fair amount of syphilis, gonorrhea, both rectal and urethral in this study, and syphilis both at baseline and during the study, showing that these individuals that we recruited for this study were patients who were at high risk for HIV, which again solidifies how well, actually both drugs work, but certainly how well the cabotegravir worked in comparison to Truvada. And that's again just showing you that. This is getting at weight gain. I don't know if I want to spend a whole lot of time about this, unless someone wants to talk about it later. There's a little bit of there's a lot of interest right now in the HIV literature about increase in weight gain on certain antivirals, including integrase strand transporter inhibitors, which cabotegravir is, or tenofovir alafenamide, which is a TAF, which is in Descovy. Going through this, I'm just going to march the slides. The bottom line of what we found here, and again, these are people who don't have HIV, is that in general, what ended up happening is it seems that Truvada, if you look up the left side, Truvada, in the first year of taking it, a lot of people lost some weight. And we think maybe that might have to do with some side effects of nausea that some people have while taking Truvada. And then once they got through that first year of losing a little bit of weight, or maybe they had some nausea, maybe across that population, the weight gain was equal between those getting cabotegravir or Truvada. There was no difference. So initially in the first year, there was a difference with more weight gain cabotegravir and less in Truvada, but that went away over time. So there's ongoing things that need to be looked at is what were the drug concentrations, in particular these 5 individuals who got HIV while on cabotegravir when they were showing up for their visits and getting their injections. Why was that? What was, what concentrations of cabotegravir were in their plasma, and were they not protective levels? Were there things unique about these people that meant that the way the drug was given to them didn't work for them? Similarly for Truvada, understanding how much tenofovir these folks had, were they really taking the tenofovir? Looking at the dry blood spots and plasma levels, in particular around the time that they got infected. And then looking at resistance, did anyone develop resistance to the drugs while they were on either cabotegravir or Truvada? I can tell you, just as an aside, at our site, we had 2 seroconversions of the ones globally, and they were both people who were on Truvada. I know that from the resistance assays that I did on them in my clinic, neither one of them had any resistance. So I suspect that they were both, unfortunately, not being adherent to their daily Truvada that they were getting. And so again, this study showed that both these drugs work very well for HIV prevention, in particular if people took the drugs as prescribed. But the cabotegravir regimen of long-acting cabotegravir that was given intramuscularly in the clinic was superior to prescribing a pill to be taken every day, with a 66% reduction in getting HIV in the cabotegravir arm versus those who were on Truvada. In general, cabotegravir long-acting was well tolerated. And again, we need to look at some of the drug concentrations in those who did develop infection in both arms to understand better how these drugs worked and why they may not have worked in very small numbers of people in the study. And again, cabotegravir is the first long-acting injectable agent to demonstrate a robust HIV prevention efficacy in men who have sex with men and transgender women. And there is a study going on in Africa in cisgender women, look to try to see how cabotegravir fares for PrEP in cisgender women compared to Truvada. And I think I'll just end the slide at that point. It just shows all the sites. Well, it shows the people, study teams and sites, including ours here in Greensboro. And I'll go ahead and stop and take some questions. I can stop sharing my, all right, get back where I am. Oh, here we are. Can people still hear me?
Yes.
Okay. I don't know if I'm not sure if you want me to stop sharing my slides or let me leave it as is for now, or?
It's completely up to you. I think either one's totally fine. So I know that we've got about 5 minutes until 11. I know Ariana had a hard stop at 11, and we probably want to conclude right at 11 just for the sake of everyone's time. But if there are any immediate questions, feel free to drop those in the chat function or to unmute yourself and ask those, and we'll try and get those covered in the next 5 minutes before we have to log off. Okay, well, I will take silence as we learned a lot and nobody has any questions. If anything does pop up, feel free to reach out to me via email and I will. Oh, sorry, we do have a question. So Michael Collins asked, I was wondering what the next steps are in the approval for the injectable and what kind of time frame are we likely looking at for the FDA approval?
GSK or ViiV Healthcare, which are the manufacturers of cabotegravir, my understanding they're applying for approval of cabotegravir for PrEP. I think it's anticipated that sometime in 2021 it will be available. I don't know the exact time. This is again assuming the FDA approves it. I will, as an aside, tell you that there's a 2-drug regimen of cabotegravir and rilpivirine. I think the brand name is Cabonuv. I'm blanking on the brand name right now, but that was approved in Canada and is approved in Europe. In the United States, it was not approved, and it consists of cabotegravir and rilpivirine in an injectable nanoparticle form like we were doing in the study. The reason it was not FDA approved last February for HIV in the United States didn't have anything to do with how well these drugs worked, but had to do with a manufacturing issue that I don't know about. It's something that the FDA knows about, and that manufacturing issue needs to be resolved before cabotegravir rilpivirine long-acting for HIV treatment is approved. So I hope that happens soon, and I believe it probably will happen in the next few months for treatment. So, but clearly that same manufacturing thing would need to be, that needs to be resolved for the 2-drug combination, but also for cabotegravir because it's made by the same process. But I'm hoping it's going to be here in 2021.
Awesome. And then another question that we have, what might explain the 5 HIV transmissions in people who got their cabotegravir injections as scheduled?
I think that, it's speculating about it. I would be skeptical that it would be resistance because integrase strand transfer inhibitor resistance is almost never occurs. So like it would be unlikely that they ran into a resistant virus. I would speculate it might have something to do with the drug levels in their body, and there may be differences. People who are larger or smaller, particularly if they're larger, they might need higher doses of drug, for example. Some people clear drugs more rapidly. I mean, I guess there could be other confounders. Sometimes if they were taking a medication, sometimes people can take medications that'll like make the liver, for example, process a drug more rapidly. Interesting as an aside, like grapefruit juice is like really good at doing that. So like if you're on medications and not good to like eat lots of grapefruit and drink lots of grapefruit juice. So there's certain, maybe some drug-drug interactions, but I would think probably there's some differences in body types and ability to process drugs that probably had something to do with it.
Great, awesome. Well, I think that does it. I don't see any other questions in the chat, and I know we are right at 11 o'clock. So just want to say a huge thank you to both Dr. Van Dam and Ariana. This was such important information, and really appreciate y'all taking the time to share it with us. Like I said, if anyone has any other follow-up questions, feel free to reach out to me, and I will get that information to the right people and get back with an answer for you. We'll also be sending up a follow-up email today with the resources shared today, as well as the recording and the petition that we mentioned. So take a look out for that. But other than that, y'all have a wonderful rest of your Thursday, and thank you so much for joining us today.
Thanks.
Great, thank you.